Hello, I'm Dr. Jason Ryan, and welcome to Module 2 of the Heart Talk video series, Evaluating Patients with Heart Failure. So when I evaluate a patient with heart failure, the first thing I do is to start with the basics, and the most important question is to ask patients, how do you feel? The history in patients with heart failure is incredibly important, and you can often determine much of their clinical status just by getting some simple information on what kind of symptoms they're having. And I often focus on the symptom of shortness of breath. A patient of mine with heart failure who tells me that they are out playing with their grandchildren, able to go for long walks, maybe even exercise on a treadmill, I know is very unlikely to be in significant heart failure. On the other hand, a patient of mine who says that they are feeling short of breath at rest and they're not moving around very much and that their weight is up, I already get a handle that they're probably in some degree of heart failure. So this question is incredibly important and really helps set the context for everything else that you'll do in the evaluation. After I get a handle on how they're feeling, I focus on the vital signs. These are very important. Oxygen saturation can be low in a patient who is in severe heart failure. Having said that, many of my patients who come into clinic in heart failure do not have low oxygen saturations. It's sort of a late finding in patients who are very sick. So if it's low, that obviously raises a lot of concern, but if it's normal, it doesn't necessarily mean the patient does not have heart failure. The second thing I usually look at is the heart rate. This can actually be very helpful. Patients who are in heart failure tend to be tachycardic. Now this can be blunted if they're on medications like beta blockers that slow the heart rate. But nevertheless, if you do meet one of your patients and they say they're more short of breath and you see that the heart rate is in the 110 range, you can right away get a handle that this is probably someone who's gone into some degree of heart failure. Next, I look at the respiratory rate. Patients with significant pulmonary edema and fluid overload will be breathing quickly. Having said that, some patients who are sitting there at rest may slow their respiratory rate down, so it's a helpful finding when they are tachypnic and breathing rapidly, but if they're breathing at a normal rate, it doesn't exclude that they may be in heart failure. And actually, the last vital sign that I look at is the blood pressure, because this can be very tricky to interpret in heart failure patients. Blood pressure can get high in patients who are having an acute exacerbation of the disease. When they have a lot of adrenaline pumping because they're short of breath and very sick with heart failure, their blood pressure will go up. However, many patients with heart failure also have chronic hypertension, so they may have high blood pressure, and it simply means that their chronic hypertension needs a little better control with medications, and it's not necessarily a sign of acute heart failure. So a high blood pressure in and of itself doesn't really help me know whether or not the patient's in heart failure. Low blood pressure is also challenging to interpret in heart failure patients because blood pressure can get low during critical illness. It can be a sign of shock, so it certainly can be concerning when a patient has hypotension. However, blood pressure runs low in many heart failure patients who are under good treatment. Multiple cardiac meds lower the blood pressure, and in fact, a low blood pressure can be okay. It means there's less workload for the heart. So when I find a patient who has low blood pressure, I don't necessarily know just by that one reading whether or not the patient is seriously ill. And a very, very important question for heart failure patients who have low blood pressure is, do you get dizzy when you stand up? Patients who get dizzy when they stand up are having orthostatic hypotension, and this means that their blood pressure is too low and they're at risk of falling down. These patients often need some type of medication adjustment in order to get their blood pressure to be a little bit higher. The one caveat to that is I do have some patients who are very, very stable on an excellent regimen and they have mild orthostatic hypotension when they stand up. And for some of these people, I just counsel them to rise from a seated position slowly and pause for a second to let any lightheadedness pass before they begin walking. Weight is probably the most useful measurement in patients with heart failure. An increase in weight can signal fluid retention because when the body begins to hold on to salt and water as it goes into heart failure, the weight will increase. However, not all weight increases mean that a patient's in heart failure. It can also be healthy weight gain from eating a good diet. The time change here is really key. I tell all my patients the simple rule of thumb that a 3-pound weight gain in one day or 5 pounds in a week is abnormal. It's very unusual for patients to gain this much weight just from eating a lot unless they are retaining salt and water. It's also very important to check with your patients when they do have a weight gain that they're weighing themselves at the same time each day in the same amount of clothing so that a 3-pound weight gain doesn't simply mean a different pair of shoes. The physical exam is also challenging to interpret in heart failure patients because many of the findings that indicate heart failure can also be found in stable patients on good medical therapy. We'll go through here each of the different physical exam findings and talk about the challenges of each one. Let's start with the lung exam. Crackles at the base of the lungs can signify pulmonary edema in a heart failure patient. However, many heart failure patients also have lung disease and other non-cardiac causes of crackles at the base of the lung. So just the crackles in and of themselves don't always help you unless they're put into the proper context of everything else that's happening. Jugular venous pressure can be estimated by examining the neck veins if you've been taught how to do this. When the jugular venous pressure is up, it can mean that a patient is retaining fluid and in heart failure. However, many of our patients have necks which make it very difficult to visualize the jugular veins. Also, some patients have very leaky tricuspid valves in their heart, and this can make the jugular veins appear elevated in situations where they are not significantly fluid overloaded. Edema is a sign of heart failure. This is swelling, usually in the lower extremities. There are two types of edema, pitting and non-pitting. Pitting edema means that when you press down the swollen extremity with your fingers and remove your fingers, a pit or an indentation remains behind. Non-pitting edema is not caused by heart failure, it's caused by other conditions. Patients who have fluid overload tend to get edema that localizes to dependent areas, usually the ankles, but in patients who are bedbound it can localize to the sacrum, and in some patients it localizes to the abdomen. We grade edema as 1+ to 4+, 4+ being very severe and 1+ being very mild. However, it's important to know that there's no agreed upon definition of each grade, and thus it's hard to compare when one person says 1+ to another person who says 2+, whether that's a true difference or just a difference in the way they estimated it. Complicating all of this is the fact that many elderly patients have venous stasis edema. The veins of our body have small valves to prevent the backflow of fluid. These can get stretched as we age, and the result is that patients can have swelling in their ankles, particularly after they've been standing for a significant period of time. This edema is not from heart failure. What this means is that just simply the presence or absence of edema does not in and of itself tell you whether or not a patient is in heart failure. So to put this all together, I guess what the key point here is that often you know a patient is in heart failure before the exam, especially if you take a good history and examine the vitals, including the weight. When I see a patient who has symptoms of heart failure and their weight is up several pounds in a short period of time, I already have a pretty good idea that that patient's in significant heart failure, even before I start to examine them. A second point is that many physical signs of heart failure are present in stable, well-compensated patients, and the key to interpreting them is the context in which they occur and the changes from one day to the next. These are our zones for heart failure. We use this to teach our heart failure patients how to identify whether they are in a stable phase of their disease or whether they are beginning to get sick. But these are also a useful way for nurses and other healthcare practitioners to understand what status their patients are in and what kind of therapy they need. We tell our patients that they're in the green zone when they have no shortness of breath, no weight gain of more than 3 pounds in a day, no swelling in their feet, ankles, legs, or stomach, and an absence of chest pain. These patients are doing very well, and we tell them to keep up the good work, take their medications, eat a low-salt diet, and weigh themselves every day. Patients are in the yellow zone when they have a weight gain of 3 pounds in one day or 5 pounds in a week, more shortness of breath, more swelling in the feet, ankles, legs, or stomach, feeling more tired. They may have new or unusual coughing from fluid on the lungs. They may be dizzy, and they may have a hard time breathing when they lie down. They may even be sleeping, sitting up in a chair. And these are patients that we tell to call their doctor. And finally, patients are in the red zone when they're having a hard time breathing, struggling to breathe even at rest, they have chest pain or discomfort, or they feel faint. And these are patients that we recommend get emergency help by calling 911 or going to the emergency room. So the best way to put together all the history, physical exam, and vital sign findings of patients and understand how to evaluate them is to go through some examples. So let's do that now. Mr. L reports more shortness of breath when ambulating to the bathroom for the past 2 days. He has also noticed leg swelling. His weight is up 5 pounds in the past 2 days. On his physical exam, his blood pressure is 150/85, his pulse is 90, his respiratory rate is 18, and his oxygen saturation is 95% in room air. On physical exam, he has rales in his lungs, his jugular venous pressure is increased, and he does have some edema. So take a second to think about the zones we discussed and think about whether you think Mr. L is in the green, yellow, or red zone. So I hope you can see that Mr. L is in the yellow zone. He has a weight gain that exceeds 3 pounds in a day or 5 pounds in a week. He has symptoms of heart failure, and he has physical exam findings of heart failure. So what you would do for Mr. L if you encountered him would depend on the setting in which you see patients. If I were seeing him in the hospital, I would think that he needs more dosages of diuretics. I would increase his dosage of Lasix or another diuretic that he's receiving. We often give them intravenously because they tend to work better when given IV than given orally. If you were seeing Mr. L in a skilled nursing facility or an acute care rehab, he would need a higher dose of diuretic. You could give this orally, or if you have the ability to do so, you could put in an IV and give him an IV dose of diuretic. If you're seeing this patient at home, maybe as a VNA, you would want to call the patient's doctor and let them know that you think they're starting to develop heart failure. I routinely get these calls from visiting nurses at our heart failure center here at UConn, and we have the patient come in, we place an IV, give an IV dose of Lasix, and then we call them a day or two later to make sure they've put out fluid and that they are feeling better. It's important to understand that patients in the yellow zone often can be managed in the outpatient setting if you get them in touch with the right medical care. Patient example number 2 is Mrs. S, who has dementia. She ambulates only with assistance. The past 2 days she's been more lethargic, she has no complaints, and her weight is up 5 pounds in 2 days. When you examine her, her blood pressure is 142/85, her pulse is 88, her respiratory rate is 20, and her oxygen level is 95% on room air. On physical exam, she has rales in her lungs, increased jugular venous pressure in her neck veins, and she does have edema. So once again, take a second to think about whether Mrs. S is in the green, yellow, or red zone. So Mrs. S is in the yellow zone, and patients with dementia can be a challenge because it's hard to get a good history out of them. But the fact that she's lethargic is very concerning. She also has a weight gain that suggests heart failure, and she has physical exam findings that suggest heart failure. So just like the previous patient, this is a patient where you would want to do different things depending on which setting you're in, but this is definitely someone that at the UConn Heart Failure Center we would try to see in clinic and treat with IV diuretics and help them stay at home and avoid having to come into the hospital for therapy. Patient number 3 is Mr. P, who can ambulate to the commode with his cane. He's been home from the hospital for a week and is eating better the past few days. He has no complaints. His weight is up 3 pounds over the past week. On physical exam, his blood pressure is 136/85, his pulse is 72, his respiratory rate is 14, and his oxygen level is 96% on room air. On exam, he's got fine rales at the base, you can't see the jugular venous pressure, and there's no edema in his legs. So take a second to think about Mr. P and think about whether he's in the green, yellow, or red zone. So Mr. P is definitely in the green zone. He feels great and he's doing very well. Something that might be a little bit confusing is the fact that he's gained weight. But there's a key piece of the history there. He was in the hospital, and many heart failure patients, when they're in the hospital, lose weight. They often don't feel well. They don't eat that much. Then when they're feeling better and they get home, they start to put some of that weight back on. So he is probably having a normal, healthy weight gain. That's a response to him returning to feeling better and eating better. And you wouldn't need to do anything special for this patient, although this is a good opportunity to reiterate the need for him to eat a low-salt diet, take his medications, and do the right things so that he stays well and stays out of the hospital. Our last patient example is number 4, Mr. D. He has dementia. For the past 2 days, he's been coughing. He's lethargic and does not want to get out of bed. He has a low-grade temperature. His weight is up 6 pounds over the past day. On physical exam, his blood pressure is 160/95, his pulse is 104, his respiratory rate is 24, and his oxygen level is 88% on room air. On exam, he has rales half the way up the lung fields. You're not able to see his jugular venous pressure, and he has no edema in his legs. So think about whether Mr. D is in the green, yellow, or red zone. So Mr. D is most definitely in the red zone. He's having symptoms even at rest. He's gained a lot of weight. And if you think about what's probably going on with him, he has a low-grade temperature. So most likely he's developed some type of infection. And infections are a very common way for patients who are stable with heart failure to get tipped over into acute heart failure. He has a low oxygen saturation level, even on room air, so he is really acutely ill and needs to be taken care of right away. If you saw him in the hospital or somewhere where you could give him oxygen, you'd want to do that right away. If you were seeing somewhere else, you'd want to get him to the emergency room as quickly as possible. So to summarize, the patient's weight and symptoms are very helpful in establishing their clinical status. And if you focus carefully on these can be helpful when other things point to gray zones that aren't as clear about the patient's clinical status. And zones are a simple and straightforward method to understanding heart failure and knowing what your patients need in terms of therapy. Thank you very much.